Hey guys, this is Abhijit Barai. In the Journal Club today, we are going to discuss about a very well-cited paper which is relevant in practice in emergency department. This is called CRASH 2 trial, which stands for clinical randomization of an anti-thrombolysin in significant hemorrhage. And before I start, I need to be very honest with you. I do not have any financial interest to disclose here. And so this is the paper we are going to talk about. So the title of the paper is Effects of Tranexamic Acid on Death, Vascular Occlusive Events, and Blood Transfusion in Trauma Patients with Significant Hemorrhage. And this is a randomized placebo-controlled trial, or RCT. This particular study was conducted by a CRASH 2 trial coordinators or collaborators. The base or the main center was the London School of Hygiene and Tropical Medicine, based in London in the United Kingdom. So this is how I am going to present the paper. So I have divided this session into three different sections. In the first part, I'm going to talk about the paper itself. So it's mostly descriptive. So what they have done, where they have done it, how they have done it, what they have found, and what they concluded. So this is completely descriptive, and I'm not going to analyze it. In the second section, however, in the critical appraisal section, I'm going to analyze based on a specific checklist. And in the third section, we are going to have a little brief discussion about this paper, about its validity, about its reproducibility or reliability, generalizability, and finally applicability. We'll try to see if we can apply the findings in clinical practice in our hospital. So let's talk about the paper itself. So as I mentioned, this is a paper which was published in Lancet in 2010, and it is a very well cited paper. There are hundreds of citations of this particular paper. So as you can see in this picture, there is a gentleman with multiple injuries, and we do not have to introduce the elephant in the room. When I did my ATLS in 2005 for the first time, so that was 12 years ago, we were told, or we were taught to approach a patient in trauma. So at first we used to walk to the patient in something called ATLS walk and make sure that the patient's airway and C-spine are protected. That was the first priority. Then is the breathing and ventilation, and third was circulation. Now, as I mentioned, that you don't have to introduce the elephant in the room. If you go to see this patient, the first priority would be to look after the patient's main injury, which is the limb injury, and there is active bleeding. So we need to control the bleeding at first. So C will get the priority, then A or B. And once the C is sorted, then we can look after A and B later. So if this patient is transferred to the emergency department, we of course follow our protocol. We assess the patient according to the ABCD approach. The special attention should be given to C. This bleeding can be controlled by different ways, by giving pressure, by putting a bandage, bringing the patient to the theater. But one of the medical management is giving this magic drug. It's called tranexamic acid. This is an antifibrinolytic drug. There are many antifibrinolytic drugs. One of them is tranexamic acid. Tranexamic acid is not a procoagulant. The way it works is it just prevents the already formed clot lysis. So when our body has got the intrinsic and extrinsic pathways of coagulation system, a clot is formed, which is nothing but a meshwork of fibrin, and there are some cells like RBC, WBC, which are trapped in the fibrin meshwork, and that is what a clot is. But the body also has got a mechanism to break down that blood clot So there is a chemical substance, something called plasminogen. When plasminogen is activated, we get plasmin, and plasmin can break down these fibrin threads, and finally that clot is broken down. So that is the usual mechanism in our body. So whenever there is a clot, the clot is broken down. Now in a massive hemorrhage, we do not want the blood clot to be broken down, because the way the bleeding can be controlled is our own coagulation pathway, and that is enough to control the bleeding. But if we let it go, then there will be massive bleeding and we will not be able to control it. If we give tranexamic acid, what it does, it blocks the lysine of the plasminogen, and without plasminogen, the clot cannot be broken down. So basically, you need to have an intact coagulation system to make sure that the body produces enough clot to stop the bleeding, and the body will also produce plasminogen to break down that clot. However, if we give tranexamic acid, it is just stopping the plasminogen to break down the clot. That is how it works. So if we give tranexamic acid, it is not going to cause deep vein thrombosis or pulmonary embolism, a heart attack or a stroke. However, if your body already has got clots, it will prevent the breakdown of that clot. Now, let us go to this paper which was published in Lancet, that is CRASH-2 trial. Now, why they have done it? So the reason they showed is that road traffic injury or road traffic accident, in New Zealand we call this motor vehicle accident, that is number 9th leading cause of death throughout the world. And it is anticipated that by the year 2020, this motor vehicle accident or road traffic injury will be number 3rd leading cause of death. And it is found in the literature that about 33% or about 1/3 of the patients who die in the hospital following their trauma is because of hemorrhage. So it can be assumed that if we can control the hemorrhage, then probably we can also reduce the mortality quite a bit. What we already know is that tranexamic acid and other antifibrinolytic drugs like Appraisal and epsilon aminocaproic acid, they can actually reduce the bleeding among surgical patients. So we are not talking about the trauma patients. These are the studies, especially the one by Henry and others, which is published as a systemic review, as a Cochrane review. It was published in 2010 and 2011, I think. So what they showed is that if you give tranexamic acid just before taking the patient to the theatre, then the chances of bleeding is reduced, the chances of doing revision surgery, that is reduced, the mortality is reduced. Among them, specifically, they looked at the tranexamic acid, and in 53 studies, they found that if we use tranexamic acid just before taking the patient to the theatre, then the bleeding is significantly reduced. So this was a study which was done by Henry and other co-authors. It is a Cochrane systematic review. This is a very high quality paper. And the key word here is that the antifibrinolytic. So it is not a single drug. They have examined the use of 3 different drugs. One of them was tranexamic acid, and one of them is epsilon aminocaproic acid. So they have shown that if we use these drugs before taking the patient to the theatre, then the blood transfusion is reduced. So what we did not know from this paper is that what is the effect of the antifibrinolytic drugs, particularly tranexamic acid, in trauma patients. We did not know that. To investigate the effect of the antifibrinolytic drugs in trauma patients, this particular randomized control trial by CRASH-2 collaborators was conducted. So the hypothesis, which was not very clearly mentioned in the paper, I assume that the hypothesis is that tranexamic acid does not reduce the bleeding among trauma patients. So this is a null hypothesis. What it necessarily means is that if the p-value is less than 0.05, then we can reject the null hypothesis. Then we can say that statistically tranexamic acid does reduce the bleeding among the trauma patient. So the way it was done is it is a randomized control trial. It is an RCT, and it was conducted throughout the world in 274 hospitals. The total number of adult patients more than 16 years of age were randomized, 20,211 patients. Among them, there are some patients who were excluded because they withdrew their consent. There were some of the patients whose consent was not complete, and ultimately there were a total of 20,127 patients who were analyzed. Now, among the patients, the inclusion criteria is that the patients had some sort of trauma. It may be a blunt injury or it may be a penetrating injury, and they were at high risk of significant bleeding, or they had significant bleeding. The way they defined significant bleeding is if somebody has got heart rate of more than 110 or blood pressure, systolic blood pressure less than 90 millimeter of mercury, and that trauma time of injury should be within last 8 hours. So this is how they have defined the significant bleeding: systolic blood pressure less than 90 millimeter of mercury and heart rate more than 110 beats per minute. Now, the geographical location, if you carefully look at it, most of the patients were from India, 21% of the patient. Then we have got Colombia, about 11% of the patient. Then Egypt, 11% of the patient. Then there was Nigeria and Indonesia. So about 75% of the patients were from the developing countries. There are quite a few European countries who participated. In North America, there are only 2 countries. One was Canada. There are only 2 patients from Canada, and there are quite a few patients from Mexico. From Latin American countries, there are quite a few countries who participated. Among Australia and New Zealand, there are 2 hospitals in Australia. One was Nepean Hospital, and the other one was Sir Gardiner Hospital in Perth. In New Zealand, unfortunately, there was no hospital participating in this study. Now, the way they have done it is that, first of all, they randomized it. They have mentioned the randomization process, that they did the randomization as a computer-generated randomization. We'll discuss about it in the second section. And finally, the participants and researchers, they were masked, they were blinded. So it is a double-blind process. And there were 2 groups of the patients. One is the tranexamic acid group, and the other one is the placebo group. In the tranexamic acid group, they received 1 gram of tranexamic acid IV over 10 minutes, and it was followed by 1 gram of tranexamic acid IV over next 8 hours. In the placebo group, they received 0.9% saline in a similar dose or similar way like tranexamic acid. So the ampoules of tranexamic acid and the normal saline, they were identical. They looked same from outside, and the researchers or the patients, they were not able to identify exactly which vial is containing tranexamic acid and which one was containing saline. Methodology wise, that is a very good way of blinding and randomization. However, there are some of the issues that I will point out later. The outcome in this particular study, there were 2 different types of outcomes. Primary outcome was the mortality within 28 days after the injury, and the secondary outcome was vaso-occlusive disease like myocardial infarction, pulmonary embolism, ischemic stroke. And secondary outcome was a need for blood transfusion and how many units of blood was transfused. Now, the results in this study, there were 2 groups, as I mentioned: tranexamic acid group 10,060 patients and placebo group 10,067 patients. they found that the all-cause mortality was significantly reduced if tranexamic acid was used. So in the tranexamic acid group, the mortality was 14.5%, and in placebo group, it was 16%. The relative risk was 0.91, which means that the risk is reduced if we give tranexamic acid, and it is statistically significant with a p-value of less than 0.05. Now, the key word here is that all-cause mortality. This mortality may be from bleeding, it may be from a heart attack, it may be from a pulmonary embolism. To identify specifically what is the effect of tranexamic acid on bleeding, they have further done some analysis, and they found that it is statistically significant. So among the mortality from bleeding itself, if we use tranexamic acid, the mortality is 4.9%, and if placebo was used, the mortality was 5.7%. Here, relative risk was 0.85, and it was statistically significant as well, with a p-value of less than 0.05. So this is what we can find, that as we can see that most of the mortality that happened within the first a couple of days, and as the time passed over, the incidences of mortality that has reduced. The red color columns, these are the death due to bleeding alone, and the brown color, that is the other causes of mortality. So as you can see, the bleeding is the #1 cause of death in the first 24 hours. But in the second day or subsequent days, bleeding is not the leading cause of death. It may be something else. It may be infection, it may be myocardial infarction, it may be pulmonary embolism, or something else. So what they have done is they have done some stratified analysis. And if you carefully look at it, you will find that only two items, one is that any cause of death and the bleeding, these are the two items which are statistically significant. In other conditions like the vascular occlusion, like PE, myocardial infarction, or stroke, there is reduction of mortality if we use tranexamic acid, but this is not statistically significant. The p-value is 0.09. If there is death in multi-organ failure, that is also reduced if we use tranexamic acid, but again, it is not statistically significant. If the patient dies from head injury, that is also reduced after giving tranexamic acid, but again, this is not statistically significant. And the other causes of death, again, that is reduced in the tranexamic acid group, but this is not statistically significant either. This is a very busy slide, but this is a very interesting slide. So first of all, let us have a look. This is called post hoc analysis according to the subgroups. So in the vertical line, there is this vertical line on the right hand side. If you carefully look at it, that is the null value of 1, which means we are looking for the differences between the groups. If you carefully look at it, these are the horizontal lines. These are the 95% confidence intervals of each of those items or variables. All of them actually crossing or touching the null value of 1, which means they are not statistically significant. There is only one item, one variable, which is statistically significant because it is not touching the null value of 1, and that is the systolic blood pressure of less than 75. So as you can see here, so this is the systolic blood pressure less than 75 millimeter of mercury. Here the this is the 95% confidence interval, which is not touching the null value of 1. Here the relative risk is 0.87, which means that if somebody has got a systolic blood pressure of less than 75 millimeter of mercury, if we use tranexamic acid, the mortality actually is reduced significantly. In other cases, if we consider the time of injury, if we consider the Glasgow Coma Scale injury type, this is not the case. They are not statistically significant. If we look at the time of injury, for example, if we give tranexamic acid within 1 hour after the injury, then we can see that the relative risk is 0.87, so this is reduced. However, this is not statistically significant because the 95% confidence interval, that is ranging from 0.75 to 1, and that means this 95% confidence interval is touching the null value, and so this is not statistically significant. If we go to the next level, so the time of injury, if it is 1 hour to 3 hours before tranexamic acid is administered, it is the same. That is, there is not much change. But what happens in the patients where tranexamic acid is given later, more than 3 hours later? We can see that in this case, actually the risk is, the relative risk is 1, which means there is risky. So what it necessarily means is that if we give tranexamic acid sooner, that is better. Although this is not statistically significant, but clinically this is significant. So if we can give tranexamic acid within 3 hours, that is better. Now this is another very busy slide. So this slide shows the various types of secondary outcomes. One of the secondary outcome was the vascular occlusive event. There is only one parameter here, that is the myocardial infarction, which is statistically significant. So if we give tranexamic acid, myocardial infarction is significantly reduced with a relative risk of 0.64 and the p-value of 0.035. In all other cases, this is not applicable. Now, the third type of outcome that we look for, that is another secondary outcome, that was a blood transfusion. And as you can see, the blood transfusion was needed in many patients. However, this is not statistically significant. So we can say that if we give tranexamic acid, the need for blood transfusion is reduced with a relative risk of 0.98, but this is not statistically significant with a p-value of 0.21. Finally, the authors concluded that if we give early tranexamic acid following a trauma patient, then significantly the mortality is reduced. Also, there is some reduction of vaso-occlusive disease, for example, myocardial infarction, that is statistically significantly reduced. However, blood transfusion, need for blood transfusion, that is not significantly reduced. Now, the second part is the critical appraisal of this paper. I have used Consort 2010 guidelines or checklist for analyzing or performing the critical appraisal. I have already mentioned many of the items from the Consort during the description of the paper. So right at this moment, I'm going to talk about those items which were not mentioned in this paper. So first of all, let's talk about the hypothesis. As I mentioned, there was a hypothesis, but it was not very clear in the paper. So I assumed that the hypothesis was, null hypothesis was, that the tranexamic acid does not reduce the mortality of the patients with trauma. Second thing is that there was no specific date mentioned. When was it done? In the paper, they have mentioned that the first patient was recruited in 2005, but they have not mentioned when the study stopped. So that is very important. The duration is important. There was no mention of the follow-up after the discharge. So many of the patients, about 91% of the patients, were discharged within 28 days after the injury, but there was no follow-up. And if there is no follow-up, we do not know exactly what has happened to those patients. Did the patient die within 28 days? Did the patient have got a myocardial infarction? Did the patient has got a pulmonary embolism? We do not know. And there was no mention about this follow-up, and there was no mention how they have addressed this issue. Another important thing is the funding. The authors have mentioned that the funders were not directly involved in the data collection or data analysis or writing of the report. However, there was no mention of the name of the funding source. One very interesting part of the paper is the some nomenclature. For example, CRASH 2, that is the trial's name, and this is the abbreviation of the clinical randomization of antifibrinolysin in a significant hemorrhage 2. Now, if there is CRASH 2, there should be some CRASH or CRASH 1. And I have gone through the CRASH original paper, but it does not have any relationship or connection with the CRASH 2 at all. Original CRASH paper, that is also a randomized control trial, which was conducted in multiple different countries. They examined the effect or efficacy of corticosteroids among the head injury patients. So that particular trial does not have any connection with the CRASH 2 trial. Now, another important aspect of the name of CRASH 2 is that this particular paper looked at the trauma patient, but in the trial itself there was no mention of trauma. They mentioned significant hemorrhage. Now, if there somebody has got bleeding peptic ulcer disease, hematemesis melina, or perioperative hemorrhage, or somebody has got postpartum hemorrhage, menorrhagia, or hematuria, these are all significant hemorrhage. But as we have seen in this paper, they looked at only the trauma patients. They did not look, and in case of the perioperative patient or menorrhagia patient or the postpartum patients. So I think the naming of the trial, that is a bit confusing and misleading. Another definition that is also I found a bit difficult to comprehend is the significant hemorrhage. The way they defined is that if somebody has got an injury, blunt injury or penetrating injury, and the heart rate is more than 110 or systolic blood pressure is less than 90 millimeter of mercury, that is a significant hemorrhage. Now, that is quite difficult to understand as well. If somebody has got atrial fibrillation and the heart rate is more than 110, then even if there is some minor injury, then that can be considered as significant hemorrhage according to the definition of this paper. On the other hand, if somebody is on a beta blocker, even if they have got massive hemorrhage or significant hemorrhage, the heart rate may be less than 110. So it does not make any sense to define significant hemorrhage as heart rate of more than 110 and systolic blood pressure of less than 90 millimeter of mercury. In the original research, they might have done something else to identify who actually has got significant hemorrhage and who does not. But in this paper, in the printed paper, it was not very clear. Interestingly, the link that was given in the paper to look at more information about the study in the London School of Hygiene and Tropical Medicine, that web page crashed. So the CRASH 2 website crashed, which is very funny. Randomization process, that can be questionable as well. Now, in the Lancet, they have published the protocol of the CRASH 2 trial, and also in the paper itself, they have mentioned about how they have done the randomization process. What I can understand is that they mentioned that there was a designated telephone service, and there was some researcher in Oxford in the UK to receive the phone call, and after the patient's detail was given to him or her, all the details like patient's age, sex, ethnicity, type of injury, various things, they were considered for randomization process. If the telephone service was not available, like from India or from other countries, then there was some packs kept in the hospital, and those packs were used, which I found a little bit complicated, because this is not a true randomization process, because they did not consider the age of the patient, sex of the patient, hospital, type of the injury, ethnicity, and without considering all those things, they have just randomly performed the test, which is not a true randomization process. We cannot claim that this was actually a computer generated randomization process. is a questionable thing. So out of these 20,127 patients, only 95 patients were actually randomized, and the other patients, that is the majority of the patients, 99% of the patients, they were not randomized in a very systematic way, which is actually a very big weakness of the study, and it has reduced the reliability and validity of the methodology. There was no mention of the statistical software that was used in the statistical analysis, which reduced the reliability of this study as well. Did they use SAS? Did they use SPSS? Did they use R? I don't know. If the statistical software was not clearly mentioned, it is very difficult for the other researchers to reproduce or to find out if the other similar study can show the similar result or not. So that has reduced the reliability of this study as well. So this is the, in the Lancet, they have published the protocol, and this is how they have shown. One interesting thing, as I have already mentioned, is the outcome. So the way they have collected the data is that there is an outcome form, and in the form they have identified what is happening with the patient. Did the patient has got an MI? Did the patient die? Did the patient has got a major hemorrhage? Did the patient need to go to the theater for controlling the bleeding? Did the patient have any blood transfusion? How many units of blood transfusion? So in this outcome form, this was all the data was collected, but there is a big but here, because only 9.2% of the patients remained in the hospital for 28 days or more. What happened to the rest of the patients? In 91% of the patients, we do not know. There was no follow-up mechanism. So if somebody has got a PE 7 days after discharge from the hospital, within 28 days after the injury, that was not recorded. So I think that is a big weakness in this study, and we need to scrutinize this matter very seriously. Another interesting part is that the researchers have mentioned in the paper that they compared the data set with the clinical notes of the hospital. This is a very vague and non-scientific way of mentioning the inter-rater reliability. There was no mention of Cohen-Kappa coefficient or intra-class correlation coefficient, which is not very scientific way of comparing the data set, and that is a big weakness. The authors have also mentioned that the outcomes were expressed as mean and standard deviation, which is a very basic statistics. We know that there are three outcomes. One is the mortality rate, one is the incidences of vaso-occlusive disease, and third one was the blood transfusion. None of them were continuous variables, so all of them were categorical variables. We cannot express categorical variables as means and standard deviation. We can express only as counts and proportions or percentages. This is a big weakness of this study. The way tranexamic acid works is that if there is already a clot formation, tranexamic acid is just preventing the breakdown of that clot. Tranexamic acid cannot form clot on its own, which means that we need an intact coagulation system in the body. There was no mention of the coagulation profile. Did the patient take warfarin before this injury? No mention. So we do not know exactly what was the coagulation profile, because that will be a big confounding factor. There was no mention of the renal function test, because if the renal function is impaired, tranexamic acid is contraindicated. There was no mention of the weight. However, the authors have mentioned that measuring weight can be difficult in a trauma patient, which I agree. However, we need to also consider that we cannot give the same amount of tranexamic acid to every patient. Somebody may have a body weight of 50 kg and somebody may have a body weight of 150 kg. We cannot give the same amount of tranexamic acid to everybody. So let's talk about the discussion a little bit. So from the discussion, what I have done so far, according to the critical appraisal of the paper and the description of the paper, I think it can be agreed that the validity of the study is questionable, the reliability of the study is questionable, the generalizability of the study, however, can be generalizable because this study was done in 40 different countries in 127 hospitals. So yes, the findings are quite generalizable. When we consider the applicability of the study to our clinical practice, we need to be very, very cautious. First of all, most of the patients were taken from India, Indonesia, Colombia, Egypt, and the other developing countries. The healthcare system in those countries are different from that in New Zealand. The demographic characteristics and the patient characteristics, the clinical characteristics, they are not comparable. There was no Maori patient included in this study. There was no hospital involved from New Zealand in this study either. Considering all these facts, I will be very skeptical about the application of the study findings to our clinical practice in New Zealand or to my hospital. There are different studies which examine the effect of tranexamic acid in trauma patients or in surgical patients, and they have found that yes, tranexamic acid is very helpful. It reduces the bleeding from trauma and from surgery. However, from this study alone, I cannot apply the findings to my clinical practice. So these are the various papers which I have used as reference. The first one is the main paper, the CRASH 2 paper, and there was a paper by Henry who looked at the effect of the various types of antifibrinolytic drugs on the perioperative patients. It's a Cochrane review. And finally, there is the CRASH 2 protocol, which is published in Lancet. Thank you very much for your attention. If you have got any comments or suggestions, please feel free to write at the lower part of this website, and I'll talk to you later. Thank you very much.